programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3, 2,
1.
Well, good morning, everybody. My name is Jens Chapman, and a cordial greetings and happy new Wednesday from the beautiful SSF studios in Seattle at the Seattle Science Foundation. Today is a very special day, April 16th. We have our visiting professor, Dr. Michael O. here from the University of California, Irvine. Fantastic to have him here. And before I introduce him in greater detail, just a quick briefing. Yesterday was the match day, the San Francisco match day for our fellowship, and we're very pleased with Dr. Jace Bauer and Dr. Floyd joining us. So Floyd Davis will join us as our second fellow. Many thanks to Lindsay Wheeler for her incredibly hard work and all those involved in the match. It was a great experience and it was fantastic to see our applicants over 60, and we'll hope to see you if you didn't make it here in our future courses. Now to the business at hand. One of the most common things that we're asked to see, and as our population is aging, all the more relevant are patients who are aging with spinal stenosis and some degree of instability. And it is so common that fusions are done, and this is why we're so happy to have Dr. Michael O. here. We want to thank the company called Extant for their financial support to bring Dr. O here. And I'm going to introduce him in great detail a little bit later still, but he's a professor of neurosurgery, and he has worked very diligently with a device called Coflex. I have a model here. So this is not CME, right, Corey? Shout out to Corey. So we can show a product name, Coflex, and I'm an advisor for the company, so I'm conflicted. But for me, this has been a breakthrough full declaration device in that I think our thinking has been too rigid in the past towards fusions and doing too many fusions, and they beget their own set of problems. So here to show us the mastery will be Dr. O. But as always, we have Dr. O in his capacity as a wisdom provider here first. So we have 3 cases from our fellows, and then we'll switch into the lecture mode. So Dr. Minisali is going to show something, and maybe we can get some insights, because one of the big questions was always, how well do they work, and aren't there some problems with them? So, Nick.
All right, good morning, everyone. Thank you very much. So I have no disclosures relevant to the talk. This case is a mid-70s-year-old female with bilateral back and buttock pain with radiation to the right anterior thigh. It's worse with standing and walking, improved with lying or sitting down. She's fairly healthy overall. She has hypertension, IBS, and then as socially, she's very active. She walks the golf course, does at least 9, usually 18 holes by walking, bikes, yoga, Pilates. Her BMI is in the 22 range. With regards to her current pain, she had a prior L4-5 interlaminar epidural steroid injection that gave about 2 weeks of relief. And as far as workup, she had a DEXA scan about 2 years ago with no osteopenia or osteoporosis. And on exam, she's fully neural intact. So here's the AP and lateral of the lumbar spine with multi-level spondylosis, but overall well-aligned, maintained disc height in the 4-5, 5-1 region. And then an MRI with mild to moderate central stenosis at 3-4 and moderate to severe central stenosis at 4-5 with bilateral facet edema at 4-5, as well as some paraspinal muscle atrophy, fatty infiltration, and no significant foraminal stenosis at that level, maybe mild.
Do we have flexion extension films?
We don't.
We don't. Was that not part of the workup?
It was not,
Okay.
which I agree we should have.
Dr. O, so very active patient. This is a ubiquitous problem. I don't know how many patients I'll see today. Of my roughly 30 patients, 25 to 30 patients, I'll have at least 4 or 5 patients who come with almost similar interchangeable images. So this is a clinical problem in a very, quote, active patient. What do you do as a routine workup in these usually older patients? What should we get? Do we need flexion extension films? Is it necessary? Do we need bone mineral density assessments, et cetera?
Agree with all of them. I think you have to get all of those, yeah. Especially with fluid in the joint like that, you have to make sure that they don't have any instability. So you have to get, it doesn't necessarily have to be flexion extension, but you have to have upright films. And sometimes flexion extension doesn't show a difference, but you'll see a difference between the supine MRI and the upright X-ray. And that's definitely a sign of instability. So it doesn't seem like there's going to be significant instability here. You didn't mention back pain. How much back pain does this patient have?
It seemed about 50% back pain and then 50% leg and more of a neurogenic claudication type.
Okay, yeah. And then as far as the bone density, I either want a CT scan, then you can kind of get a sense of what their bone density is from the region of interest kind of measurements, or you need to get a DEXA, especially if you're going to put any kind of implant in. If
How
you're not
readily
going
would
to
you, I'm sorry, I didn't interrupt you. Repeat, so she had one 2 years ago that was normal. Would you try to repeat it prior to this, or would you be okay with that?
2 years ago, I tried to get one within the year, but if she has no other concerns, I would take the one from 2 years ago.
Sure.
Yeah, she's already 70 years old, is that right? Yeah.
So the other question, we'll obviously talk about this little device called Coflex, and we have an incomplete set of cards here. A deck of cards is incomplete. Fluid in the joint, are there gradients of seriousness? And maybe address the question of facet joint angles, the inclination angle of facet joints, meaning more coronally versus more sagittally oriented joints. So fluid signal change is obviously a sign of some instability. How severe does it have to be? How much does it have to be significantly problematic? And does facet joint angulation matter?
Yeah, certainly the angulation matters. The more coronal, the less likely it's going to slip. If you have about 2 millimeters of fluid in that joint, that's when I start getting concerned. But again, it's not just the MRI. It really is you have to get something that's dynamic, either the upright flexion extension, or you have to have some evidence that if they have significant instability, then we're not talking about a non-fusion device, we're talking fusion for those cases. But this one looks like it has a pretty good disc height. It has focal stenosis at that level. The reason why I asked about back pain is if there's really minimal back pain, then I don't plan on placing a Coflex device at all. I just use the similar technique, distraction, and do skip laminotomy, decompress focally at that level. Because one of the advantages you get from the Coflex is some offloading of those facets, and that's probably where the back pain is, since the disc looks pretty good. So there's only so many generators for that back pain, but if they do have 50-50 back pain, leg pain, neurogenic claudication, that's the ideal candidate I would consider this Coflex.
Do you mind scrolling through? Does this patient have a disc herniation also, or not? And that's sagittal. It looks like there might be some.
It looks like there's a little synovial cyst starting on the left.
Synovial cyst, yeah, I'm not sure. There's something on that sagittal that's struck my eye. I think Dr. O is right. There's a synovial cyst that's kind of grown forward.
There's some fluid in the joint above.
Yeah.
And then at 5-1, there's also.
Right. Okay, and then the other question I have is, when we talk about non-fusion options, I hear this patient is very active. Now, I came to doing this procedure, this Coflex device, from a precursor, which had a very different mechanical feature, it was the X-stop. And we use that as a kind of a salvage procedure for very sick, non-active people. How does activity play into this? A very active patient, is that a contraindication to have a non-fusion device put in?
Yeah, I think that one of the differences between Coflex and X-stop is that X-stop belongs in that category of interspinous spacers, and those all depend on indirect decompression, because you're not actually removing the bone or ligament that's causing the compression. So X-stop, or there's now another one called Vertiflex that actually pain physicians are putting in because spine surgeons stopped doing it. They're doing those procedures, and it does have a limited role in those exact patients that you described, really sick, really not good surgical candidates. If you can give them a little indirect decompression, that might be all they need. But the problem with those devices is that it's interspinous. In the interspinous space, there's more chances of problems with fracture of the spinous process, of subsidence, loosening, all of those kind of problems. With this device, it's interlaminar, and it's also with decompression. So I think the decompression is really one of the, at least the two hallmarks of this procedure. You have to do a good decompression. And as I started doing more of these Coflex cases, it made me a better decompression surgeon. I think my decompressions are more focal, targeted, and then to be able to leave a device in that's non-fusion afterwards that helps with that facet offloading, prevents that foramen from collapsing later on. I think those are all worthwhile. And so, again, in this, it's easier when you're talking about putting in a Coflex non-fusion device instead of a fusion, so it's like a fusion minus procedure. But when you have a perfectly good procedure like laminectomy, and then you're adding something to that, you have to have a good reason to add something else. And I think the good reason is to maintain that foramen height and to offload the facet joints and help with the back pain.
Yeah, agreed.
Great points. And one more question, the obvious next question. Very active patient, 70 years old / 70 years young. This patient has any chance to possibly live for 10, 20, 30 more years easily, if that patient takes good care of themselves and is active again. How long does it last? I get asked that all the time. How long does it last? What do you tell patients?
I tell them my experience is 10 years. I tell them that the published reports go out about 10 years, and my personal experience is 10 years. I've been using this product for over 12 years. And I've had patients come back to me they come back to me with different problems, but it's not because of the Coflex, and it's not because of the index level. You know, the part of the promise of doing a non-fusion is that it prevents adjacent level. It might slow it down, but it doesn't prevent it. So they still come back. But I do think that it does help. Certainly compared to a fusion, it protects the next level.
Great points. Okay, Nick, take us forward. So we have no flexion extension films, and I assume no CT scan.
No, so like that's why we brought up the
Two question marks.
She did have a DEXA, but no
Okay.
recent CT.
We'll let that skip.
So the patient underwent an uncomplicated L4-5 bilateral hemilaminotomies, medial fastectomies with Coflex insertion, and was discharged home the same day. Some critiques here. I think we try to generally set this deeper. As you said, it's an interlaminar device, not an interspinous.
Using the cursor, can you show us where you usually anticipate that to be? And Dr. O has a very nice video prepared to show how it's right around there. Yes, that's probably the interlaminar space. Did you do a metal myelogram? Did you do the Woodson probe on the dorsal dura yeah, so this is a little technical pointers. I think that's important because this device is, I think, amazingly designed because it's rounded and has no sharp edges, and you can actually put it right next to the dural sac, as we'll probably see with Dr. O's example later. So it's a little bit dorsally placed. It's more interspinous and interlaminar, right? Dr. O, do you mind critiquing? This is not my case, and the colleague's not here, so go have at it.
No, you certainly want to get it interlaminar. That's, again, as you mentioned, the distinction, this device is interlaminar, not interspinous. So yeah, that comes with some of the prep. I'll show you in my video how you have to drill down a little bit on the lamina, create a groove so that it sits down a little bit further. That's important. But I think it's a very stable device. It's very simple. And when you look at this tray compared to the trays that usually get open for a fusion, yeah, there's nothing, no comparison. It's one box that they open up, really.
So, Ben, can you focus in on Dr. O? I'm going to give him a plastic model and my high-tech pen to show us what he thinks about the decompression on this company plastic model, and maybe on the level below show us how high he should go, and we'll see it in the video later. High-tech tools.
All right.
The camera will come in, just robot camera is going to focus in on you.
So this is the company branded model, and I think they do a little bit of a disservice here because you can see that this is a very large laminotomy. I don't think you need to do that in this kind of case. You really need to just get in there, and you can see how large this laminotomy is. And so, again, a little bit of a disservice to the procedure itself. It's much less invasive than that. You really need to just get to the ligamentous attachment, undercut on this side, use a curved Kerrison on this side, and that's about it. In terms of how deep you want to go, again, you don't want it up high in the spinous processes. You want these teeth to be into the lamina over here in the bottom, as well as there's another teeth here. So that even if there is a spinous process fracture, as long as you've buried it into the lamina, it still stays there. I haven't seen any of them back out.
Great. All right, let's commence with the case.
So at her first post-op, she was discharged home, did well. First post-op visit, she was reporting improvement in her pain, some soreness in the right thigh still, which was present pre-op. But she's back to walking 2.5 miles a day, going upstairs, doing yoga, weaning off gabapentin, taking Advil as needed, no recent falls or anything like that. This was with one of our, not the attending provider. This was her first post-op. So I think given she was doing well, even though these x-rays show that maybe there has been some fracture or failure.
Do you want to expand on the maybe with a cursor on the AP?
Yeah, so on the AP, this is definitely kicked posteriorly from where it was intra-op. And then on the AP there, you can see it's kicked to the patient's right rather than in the midline as it was before. So there's a comparison. So, at this appointment, she had been doing well. She was more active. I think maybe the unfamiliarity with these particular implants with the provider who did see her, they said it looks great. Follow up at 3 months. The 3-month x-rays literally are virtually identical. Really no worsening, but again, generally doing well. Some clicking now while she does Pilates and yoga, but overall, she's expressed satisfaction with her surgical outcome. Walking distance even further now at 3.5 miles, and again, she's still very active. In the interim, but we would normally see her at 6 months post-op. I think between the 3 and 6 month period, there was some worsening pain. She felt like she was actually more mobile. So after discussion with the patient and kind of her symptoms, a CT was ordered, which does demonstrate this fracture of the L4 spinous process and displacement of the Coflex device laterally. Again, I think this was a implantation error. I think the two things we already discussed were maybe a little bit too cranial of a decompression, so you have less spinous process to lamina kind of bone. She's also very small, so even though this I think this was an 8, there's some considerations there. So at this point, I guess the question is, what should we do now?
Now do you have flexion extension films?
No.
You torture me. The currency of stability is a dynamic
Yeah,
stressing,
I think she
right?
has a visit incoming. Like this was ordered She does have a visit coming up.
So still playing with half a deck of cards. And
But she's having worsening of some back pain, but not the neurogenic claudication. That's still
Yeah, it
resolved?
seems like she's walking very well. So I guess, it kind of seems like the decompression worked. But she is having some back pain, clicking, and she does feel like she has more spinal mobility maybe than she used to, in not necessarily a good way. But that obviously very subjective.
I'm not sure I would operate on her now. I would just follow this. I mean, we don't like the fact that the rostral end has cracked loose, but the bottom end is still in there. The main goal of the surgery was the decompression. And I'm not sure, without any flexion extension films being available, that she actually needed a fusion. She had very, what I would call coronally oriented joints, so they're not sagittal. And the main point about that is that there's no inherent instability. The disc is well preserved, as Dr. O has identified, and I concur. A decompression might be all she needs, and if on flexion extension films there's not some horror taking place, I would not tend to treat the x-rays. I would see how the patient does. I would give a reaffirmation and core exercise directives, but I would watch that. Again, I don't like the fact that this broke, and we've identified the two main things. The decompression was taken too high, probably. If you stop on that coronal image, you can, by the way, see how high those
It
inverted
doesn't
U-cuts
look
are.
as high.
But on the sagittal, the implant is way dorsal to where we want it to be. So, all right. So
Yeah, I think a couple points you mentioned before is if you go to the initial images, if she's a thinner person, smaller, and if you've shaved down too much of that spinous process, you don't want to over crimp. I think people, when they start on this procedure early on, they don't know their own strength, and they just clamp down on the crimpers, and you don't need that. That's not where you're getting the anchoring of this device. It's not anchoring to the spinous processes as much as it is to the interlaminar space. And so over crimping it tends to cause this kind of problem.
That's a great point.
fracture.
And
of
you
it.
can see it's definitely tight.
And then the second point is that we should never just treat the image. I agree with that comment as well. Just because she has this fracture doesn't mean she needs a fusion. She didn't need a fusion on the initial assessment because you have hardware complication. It doesn't necessarily mean that something's changed and now she needs a fusion. She might, if she continues to have pain from that fracture site, then you might need to remove it, but that doesn't mean that you need to do a fusion. So I agree with that. And Dr. Chapman keeps mentioning the flexion extension. Whenever you're talking about fusion, you have to have some dynamic study to evaluate the instability.
Yeah, agreed. And so she does have an appointment coming up to kind of further discuss, get an exam, and some flexion extension views.
okay, thank you. All right, next, shall we go for Dr. Hogshead? So this was a defeat, and we have this quarterly arthroplasty forum, and at a future point, maybe we can have you lecture there remotely, you can stay in California. We show triumphs and defeats, so we wanted to get the defeat out of the way. Hopefully there won't be more defeats now. So Dr. Hogshead came originally from the DFW area. Nick Misali, as you could see, is from the Philly area. And before Dr. Hogshead can say anything, I take full blame for this fusion. I did this a long time ago, and I was a total fan of Charlie Ray's, a visionary surgical colleague from Virginia also. And I did this, okay? So I would do it differently nowadays, but this is my doing.
All right, we'll go easy on you on the previous fusion outside medical doctor. So this is an 80-year-old female with worsening low back pain that came in with these x-rays. States that her back pain is much more worse in the mornings and has intermittent episodes of bilateral lower extremity paresthesias and pain. She's done relatively well from her previous fusion. She remained very active. She's a very active person, less in the last years with her worsening back pain. She completed some physical therapy with some improvements, but again, she's very active person, goes on hikes, and even the smallest changes for her are very impactful. She has this past surgical history of a L3, L5 posterior instrumented fusion about 12 years prior, and she's got a past medical history of high blood pressure and osteoporosis. Her social history is unremarkable. So no bowel or bladder symptoms. She's got normal gait. She's a BMI 23. She's preserved motor strength, some subjective sensation, deficits in the left lower extremity. You can see there on her ODIs and her pain scores that she's done minimal disability relatively well up until recently. Last year, she's gotten progressively worsening back disability score. These are her flexion extension views that were obtained in office. Apologize for the twisted image there. You can see that she's got a stable hardware fusion with spondylosis worse at those T12 to L3 levels. She does have some L2 and L3 retrolesthesis, about 4 degrees disc angle excursion on flexion extensions with compensatory hyperlordosis above her fusion. And then she's got also noted a stable T12 wedge compression fracture as well that's been notably stable on previous imaging serial exams. Here we can see MRI, sagittal, and axial demonstrating moderate to severe central canal stenosis centrally and foraminally bilaterally at the L1, L2, and L2, L3 levels there.
Again, I want to point out the very straight fusion, which I am responsible for. But she was actually very happy, and without mentioning the specialty, but she actually won. She won Olympic medals in 2 different Olympics. We won't say which ones. And she's from the European area, and she's relocated here and had a very successful life here for 5 decades, and very active. She had a known old compression fracture at T12, which we treated her for with our mineral metabolism clinic. So was active and engaged with that. And here we are now. We have fusion disease. Would you call that fusion disease, Dr. O?
Adjacent segment disease, yes, at both of those levels. And, I know you've done the mea culpa on that case, but I think the fact that she had 14, 13 years of excellent results, I would take it easy on myself for that outcome. She's certainly a little bit straight there where that previous fusion was performed. She's got the collapsed discs, the 2 levels above. I'm sure what we're going to see is a Coflex case because that's what we're talking about. But these kind of cases, I tend to look at them as potential lateral cases, as additional fusion. So standalone additional, especially if they have those sclerotic end plates, then I feel that I can get away with without some of the risk of subsidence. And I've done 1 and 2 level standalones in these adjacent segment cases. But I'd love to see how you tackled this with a non-fusion alternative.
So I tackled this with talking to the patient repeatedly. And I had warned her, by the way, I use a 10-year paradigm for my fusion patients. I tell them 10 years and then adjacent segments will fail in a high likelihood and hopefully won't be surgical. I tell them 3 out of 10 patients will need another surgery by 10 years at latest. And the number is probably really higher. That's the famous actually UCLA data from Jeff Wong when he was at UCLA. So we talked. And I told her what you did. I said, most likely we will have to fuse you, and here's a question coming for you, Dr. O. We'll have to fuse you, and I'd probably go to T10. I don't like to stop at the thoracolumbar junction. Would you stop at L1? Would you go to the pelvis? She's postmenopausal. She's battled, as is evident, with osteoporosis.
She's how old right now?
80.
80.
Yeah, I wouldn't go across the thoracolumbar junctions. In that age group, they tolerate more focal correction, so I really would consider just 2 level standalone.
But she had a compression fracture at T12.
I wouldn't, yeah, but I wouldn't be putting a interbody at that level. I would do just the 2 levels above the fusion.
Yeah, so I was worried about T12. We had selective fusion discussions, and I personally advised against stopping at T12. I told her, I didn't threaten her, I told her I would be comfortable going to T10, and I would go to the pelvis based on what in the SRS we consider mainly, or the mainstay now is going to the pelvis in a postmenopausal female. But she didn't want that, and so we continued with interlaminar injections in her case and more rehab. And again, this is a unbelievably fit person. She is very impressive. She looks amazing. Carry on, what do we do?
Yeah, so these are intra-op photos. We proceeded with multi-level Coflex with bilateral hemilaminotomies at each level at the 2, 3, and L1 levels, AP lateral intra-op photos there. These are her x-rays from 2 months out, doing very well, symptom-free at this point. And then she's a longer-term follow-up. We have from x-rays from about a year out, flexion extension. Here you can see stable. She was actually in a car accident that resulted in a sternum fracture about 4 months prior to these x-rays, about 5 months after her Coflex surgery. And but she's recuperated well from that, and from a low back standpoint, doing fairly well.
So for me, she had undeniable stenosis symptoms, and as I've practiced surgery for a number of years, for me, and this is a question for you, the neurosurgical colleague who does a lot of spine surgery, but is also a functional neurosurgeon, the pain imprint on our brain is far higher from neural element entrapment than from instability, short of a catastrophic structural failure. At least that's my perception. Any thoughts on that? Should we place a priority on neurologic?
Yeah, no, absolutely. I think that's what we're good at consistently improving is the neurologic symptoms from nerve root compression. This patient, as part of your presentation, how much of hers was back pain and leg pain?
I would say it's predominantly back pain and
Predominantly back pain.
yeah, and it sounded like neurogenic with the spondylotic component.
Yeah. So this is obviously off-label use of this device, but we do a lot of things in spine surgery that's off-label, and I think going back to the principles, you're going to get the direct decompression, but what sounds like she needed more than the direct decompression because of the back pain is some offloading of those facet joints. And so if you can obtain that without fusing and using this device, I think, that's the outcome is the proof in the pudding, right? So that's a great result. It's something that I've been a little bit wary of doing, and maybe a couple of cases like this, but I'd love to see more of these kind of examples.
So the off-label thing I want to stress, we're not advertising this. This was also the product of, I forgot how long the period was, but probably about a year of iterative discussions of what to do. And my initial inclination was to fuse her, but again, she wanted nothing of that. She'd walk out of the clinic literally. Yeah. So this was, and I document that in my consent, actually. I write down off-label use and I put it into my note as well. So this is not an advertisement for the company, but when you leave or when you have spinous processes intact, like what we fortunately had done at the rostral level fusion, I have off-label with documentation done this in selective cases because if I had started fusing her at other levels, this would have just kept going, and this was an outpatient surgery. Yeah.
No, I think a couple of things in the story justifies this more. One is that it's not, if it was mostly foraminal stenosis and she had a lot of that thigh pain coming from this, then the indirect decompression you get from a large interbody lateral approach is, I think, a great procedure. But if her predominant pain is back pain, it's a lot to do 2 more levels of fusion to try to tackle back pain, because our success with that is not as reliable and as good. So if her primary complaint is back pain and you have something that can stabilize that level without a fusion, it's a good option, and certainly in this patient, it worked out very well.
So far, so good. Okay. Let's go for one more case, and then we'll ask Dr. O to present. Thank you, Cameron. And next is Colin Gold, a neurosurgical colleague from the University of Iowa. Again, done an outstanding job like all of our fellows have done, and he was given another case with a very difficult challenge.
Yeah, thank you. So this lady is a 70-year-old woman who presents to clinic with bilateral foot numbness that mostly occurs with walking, gets worse the farther she walks. Her additional symptoms are low back pain, decreasing walking tolerance, and progressive urinary incontinence. It's been going on for over a year at this point. She has a past surgical history of L2, L3 laminectomy in 2010, done by an outside surgeon. No significant past medical history. She lives with her husband, works as a window arranger, which I recently found out is a very highly sought after job, and then is an active smoker, will not quit. On physical exam, the patient has bilateral foot drop, left worse than right, and then diminished sensation in the bilateral feet, in no particular dermatomal distribution. These are her scoliosis x-rays. So she has a pelvic incidence of 50, pelvic tilt of 20, lumbar lordosis of 52.6. I didn't include the flexion extension x-rays, but she has L5S1, 4 millimeter anterolesthesis that's stable on flexion extension, and L1, L2 retrolesthesis of 4 millimeters, also stable. And then on the left, we have an MRI. So you can see significant central spinal canal stenosis, probably worse at 3-4 and 4-5. And then again, the prior decompression is at 2-3. And then foraminal stenosis on the concave sides of that coronal curve. And then this is just a static picture of the X-ray to show the CT to show the coronal deformity.
So, do you have more slides to show?
No.
Dr. Gold, you come from one of the premier programs in the country, University of Iowa, great neuro and great ortho traditions. What would you have done? What do you think your attendings would have done? And this is a very accomplished lady who is just to give you the clear picture, a dedicated smoker. And she works for a very large corporation in a high profession job. It's very competitive. And she makes it abundantly clear that she will not stop. And by the way, her vessels, I checked her, I actually sent her to vascular surgery. She has a fourth spinal column with a very well-matured atherosclerotic cuff around her aorta and bilateral iliac system. So she has normal, I mean, I don't know how this person can function because her arteries are encased in calcium.
Yeah, no. If someone is adamant about not quitting smoking, I'm adamant about not doing any fusions. So that's just the trade-off. So there has to be that commitment to quit. So if she's not going to do that, all of the fusion options are off the table. But I keep coming back to back pain versus leg pain. It seemed on your presentation that leg pain
Correct.
is her main.
Yeah. Back pain was secondary to the foot numbness and walking limitation.
Yeah, numbness, walking, pain. So in that case, something like a limited decompression of the worst level on axial is at 4-5?
3-4 and 4-5.
3-4 and 4-5. How does the surgical level look? 4-5.
That's 2-3, the prior surgery level.
I did not do that, so this is done elsewhere.
Yeah.
Not pretty.
Yeah.
And nothing's pretty here. I mean, from L1 through S1, there's a lot of decay.
No, so something non-fusion. So either just a laminectomy or a laminectomy with a Coflex, I would consider in this patient. Again, the thing that makes this a laminectomy plus case for me, and I would consider Coflex, is because of the additional back pain. So it depends on how much they have. And certainly, and if they have some of this adult degenerative scoliosis, we don't have evidence to prove it, but I figure if I leave a Coflex device and stabilize that segment, it gives them more of a chance that we won't have progression of that curve. So I think it justifies a 2-level Coflex case with decompression.
So what do we do?
Exactly that. L3-4 and 4-5 bilateral laminotomy and Coflex. Post-operatively, patient discharged home on the same day as surgery. At 3-month follow-up, back pain has improved to nearly negligible. Walking tolerance has greatly improved from about a half mile to basically unlimited. Foot numbness is starting to improve, which was actually kind of discussed that it may not, so even better than expected. And the patient is still a dedicated smoker.
And she will need her hips replaced. We've talked about this for a long time. I've, with great interest from my orthopedic spectacles, seen her cartilage in her hips. I followed them avidly, examined the hips, and in my observation window of now, I think 3 years, I've followed this patient for a long time. We've had a lot of battle of the wills, and I've lost every single time. Her hip cartilage has degraded. She will undeniably succumb to needing hip replacements. But I was very happy. She was very happy. She had an outpatient surgery, and she's actually very functional. She's done her job again, and she literally went back. Activity restrictions. When you put a Coflex in, what do you tell a patient they can do, and when? Do you put them into a brace?
So I tell them 2 weeks, no bending or lifting. 4 weeks, I start them on some physical therapy, but it's mostly isometric and core exercises. In terms of the main thing that I'm worried about is hyperflexion. I'm not as worried about the extension exercises. So I let them do things like Superman, those kind of things. But I remind anybody that gets back surgery with me, I tell them that this is your body telling you that your back is done taking care of you. You have to take care of it. So something's got to change. There are some patients that are just adamant, especially the golfers, that they're not going to change anything. They're going to go back to exactly what they're doing. I tell them, I try to let them go back to some of their activities, but just to modify it. Is that you could certainly go back to golf after things like this. You can go back to running, but you have to be a little smarter about it. It's that phrase about the definition of insanity. You can't keep doing the same thing and expect a different outcome, right? So
It's a great point. And Dr. Randy Davis, and by the way, Randy, always great to hear from you, and thank you so much for your support and interest in an ongoing fashion. He had a question about the facet joint inclination again. 45 degrees is kind of our arbitrary tide mark. Is that a dividing line in terms of more sagittal versus less sagittal? How do you use that information of
about the
sagittal
same.
inclination?
yeah, very, very similar. 45 is where I cut off that border. Really, the proof is, again, in the symptoms, whether they stand, they have to have some evidence of anterior listhesis when they're upright or on flexion extension x-rays. So that actually matters more to me than the angle of that facet joint.
Great. Shall we invite you to the podium? Sure. So I'll step there with you. It's a great honor to have Dr. Michael Owen. It's an enjoyable conversation already. I hope you in the audience enjoyed it as well. And many thanks to Extant for sponsoring the trip. Dr. O is a professor and vice chair of neurological surgery at UCI Health. He did his residency at USC and then went on to doing his internship at New York Medical College and, at Allegheny, and then did his neurosurgery fellowship and residencies on the East Coast in Toronto, first for functional neurosurgery, and then residency in Allegheny, and he was chief resident also. He has frequently published. He's been a great colleague. He's been very influential in advancing surgical techniques and minimally invasive techniques. And for me, and I'm revealing my bias here, the real breakthrough in spine surgery is not less sizable incisions, but maintaining motion and functionality of the spinal column as a motion unit also. So it's great to have you here, Dr. O, and we're very curious to hear about your further thoughts on how to use the Coflex device for the benefit of patient care. Thank you for coming.
Right, so I'll just go straight into describing this Coflex device and why it's part of my toolkit and armamentarium. Again, as you can see in this little graphic here, that it allows flexion, compression, compressible and extension. So it's, again, a non-fusion device. It stays in the interlaminar space. It offloads that joint, and it maintains that foraminal height. So those are kind of the selling points of this device. And if you have one of the reps come in, that they'll pitch that. The question is when to use it and what kind of evidence there is. So there's data that goes back to their initial IDE. Certainly it's an industry-sponsored study, but there's a couple of randomized control studies really that demonstrate that this does work as well as a fusion in terms of pain, in terms of disability scales, in terms of patient satisfaction. So if it's as good as a fusion in the short run, and it has the potential of not causing adjacent segment disease, lasting longer, then it's something you have to consider when you're talking about considering a fusion. So that's when I started thinking about using this device, is if I can offer my patient the same outcome or even better without doing a fusion, why would I do a fusion? So that part was easy. The harder part of my practice to transition was if I have a perfectly good procedure, which I thought was a laminectomy, why would I add a device to that procedure if there's no instability, for example? If I wasn't considering a fusion, and we'll talk about some of the reasons later on, but it has to do with maintaining that foraminal height so that they don't have recurrence of those neurogenic claudication symptoms, recurrence of radiculopathy later on in their course. So in the years I've been using this, this came out, it's been available in the US for at least 12, 14 years. I've personally been using it 12 years. And I think that that's one of the testament to any kind of procedure, is that anything that you do, if you're still doing it 10 years later on in your career, it's stood that test of time. There are a lot of procedures that we think make sense, that there's some evidence published, and we start doing it and realize that the reality doesn't meet the publication, right? So I was talking to Dr. Chapman last night about what kind of standards I use in terms of altering my practice. And certainly you have to have those scientific studies, the randomized controlled studies, you have to have registry data. But for me, it really comes down to having someone, a trusted mentor that does something and they adopt the procedure and 10 years later they're still using it. It's hard to argue against that kind of evidence. It's not level 1 randomized controlled trials, but for me, it's almost better than some of those randomized controlled studies. So this is how I got involved and started using this, because the research was there, the controlled studies, in both as an alternative to fusion and as an adjunct to laminectomies. There's evidence there, and it made sense. And my trusted mentor was using this as well. I'm going to go straight into this case presentation. It's very similar to the presentations of the residents. Most of the patients you'll see are older. That's where lumbar stenosis happens. This patient is 79 years old. I keep emphasizing, trying to figure out what their main symptoms is, whether it's back pain or leg pain. And for the fellows, once you get out into practice, you'll encounter lots of patients that are very reluctant to pick what their number one complaint is. They say, it's all of it, doctor. It's back and leg. What? It's the same thing because it's coming from the back, right? So they won't usually make them pick one. I say that if you had a token, if I gave you a token, you can only use that one token for back symptoms or leg symptoms, what would you pick? And so that's how I kind of differentiate. It's really important there because if they pick back pain as their number one problem, then really the back pain that we can solve as spine surgeons due to some instability. So if they have primarily back pain as their number one problem, and they don't have evidence of instability, they don't have bad fluid in the facet joints, they don't have synovial cysts, they don't have any instability on dynamic studies, then I'm thinking of non-surgical or less surgical procedures. I work with a group, I'm president of a group called the Pacific Spine and Pain Society. It's a society of over 3,000 pain physicians and about 200 spine surgeons. We try to balance both fields, and there's lots of interventions now that are coming available for patients with primary back pain. So there are procedures where you can put multifidus stimulators in to restore some of that balance in their neurocircuitry. So neurostimulation is one method of treating back pain, and then there's intercept procedure, which is the basivertebral nerve ablation. So I really start, with my interaction with the interventional pain doctors, I'm thinking more of those kind of procedures when someone comes in with predominant back pain. But this patient, and the classic patients we'll see with lumbar stenosis, have leg pain or neurogenic claudication symptoms as their number one complaint. So when they have this and they fail conservative measures, most of these patients don't have a significant weakness. Here's the MRI. You can see that they have two levels of stenosis. One's moderate, one's severe, and we did the exact procedure that we talked about on the other patient. So one of the things that I do differently is I use these Casper pins for distraction when I'm doing the procedures. This came about from just doing ACDFs. We use Casper pins in our ACDFs, and when we do that, we notice that the posterior ligaments get tightened up, and it's a little bit easier to do that procedure because it improves our visualization. It makes it easier to resect the ligaments. So I thought, why don't we do this when we're doing lumbar decompressions? So I started doing this with the Coflex because it allowed me to preserve the spinous process more, as long as you don't break the spinous process with the Caspar pin. So that's one of the risks. So usually what I do is I make a midline incision, I drop in the Caspar pin first as soon as I identify, and that Caspar pin becomes my internal marker of localization. So I just get one X-ray, it's very efficient. One X-ray, I know I'm at the level above, spinous process above or below, then I can move my incision up or down. So I just start with a very small incision to get to the spinous process. Spinous process becomes my internal landmark. Get one shot, extend the incision up or down, drop in the second one, cut through the interspinous ligament, and then distract a little bit. The key with these Caspar pins is that you don't want to over distract because, again, we want to preserve that spinous process. There's certainly designs that we can make that doesn't involve pins, clamps, or hooks that might do the same things with less risk to fracture it. So someone's going to develop that, I'm sure. Once we have it distracted, then we can bring in the microscope, and I'll show you what we do underneath the scope. But this idea of distraction, I started it with Coflex, but now I use it for even my just standard laminectomy, is that I've gone away from doing open full laminectomies. It's almost never indicated in my hands any longer, is that I'll do, if I have multi-level laminectomies, I'll do small mini open skip laminectomies at each level, and by dropping in these Caspar pins, it makes that procedure so much easier. You can certainly do it with loops, but I bring in a microscope just because of my neurosurgical training, and it's very efficient and very fast, as I show you in the video. So this is the main part of this talk, is once we have the Caspar pins in, so you stretch it open, and what it does is it really pulls apart that ligament. The first step is to is really just to detach the ligament. Is you don't do a wide laminectomy. I'm not trying to get even into the 50% of that medial facet. All you have to do is go across, and I use a 6 millimeter diamond burr. There are now more ultrasonic drills that are coming into use, so that might make it even safer. But the diamond drill, as long as you have it well irrigated, it's fine. I don't use nerve hooks. Usually I use just a kerosene as my nerve hook. And because the ligament is on tension, it comes free much easier. You'll see that it looks a little bit aggressive, but most of the movement is lateral and up and out. I use the instrument as my Woodson to sweep and then bite and elevate. And really, I don't take much of that lamina, just enough to detach the ligament. I do want to undercut some of that medial facet because that's where the lateral recess stenosis is. So you have to do that. And once you get across here, this is usually the dangerous part, but because, again, there's some tension on that ligament, it's much easier to come across the ligament. And my CSF leaks have almost completely gone away once I've adopted this technique, because you're not trying to get your kerosene underneath the ligament that's indenting the dura. Instead, the ligament is stretched out and you're able to just go there. This is another instrument that curved kerosene is great for the same side so that you don't have to switch sides. So if you use a curved kerosene for the ipsilateral side, a 2 millimeter straight for the contralateral side, you don't have to switch sides and you're really able to undercut that. And certainly with the kerosene work, you want to follow the root, the direction of the nerve root, sweep it up and out, and then you can be fairly aggressive with that. They make these in multiple sizes. I use just the 2 millimeter once I go out the foramen. And then you feel around and take some more bites. So the question about how much bone to take, it came up, and then I use a little bit of flow shield. The question about how much bone to take came up earlier, and I think that's one of the keys, is that you don't have to remove much bone at all for a laminectomy. You do have to resect some of the facet overgrowth, but you don't have to do a medial facetectomy to get a good decompression. You just have to undercut it. It really helps if you use the right instruments, which is that curved kerosene, ipsilateral, 2 millimeter going out the other side. The microscopic visualization does help. You can help with making sure you get good lateral recess and foraminal decompression. The other thing to do is really, even before I do this part, you want to prepare the spinous processes. So I said that I drop the pins in, section the supraspinous process ligament, and then what I do next is I drop my diamond drill down to the spinal laminar junction. If it's at 4 or 5, I drop it right down on 4. And then usually that spinous process extends out a little bit, so you do want to flatten it out. So I get to the bottom of that spinal laminar junction, turn on the drill, and just pull it straight up so that I get that spinous process flattened up. It helps create that a visualization corridor, so it helps with that. It also is going to help with placement of the Coflex device so that there's more contact to the lamina. So if you follow those steps, again, use cast bar pin, distract, shave down the overhang of the spinous process that's above with your diamond drill or whatever drill you use. I strongly also recommend using a diamond drill for these kind of procedures instead of any cutting. As long as you have a diamond drill and you're properly irrigating it and doesn't overheat, you're going to be pushing the dura away once, if you're close to it, whereas you won't be cutting through it. So cast bar pin, shave down the spinous process, don't over distract, give a couple clicks to your cast bar pin distractor, bring in your microscope or loops, use a diamond drill, just detach the ligament, and then make use of the curved kerosene. That curved kerosene is great for the ipsilateral side on a ACDF as well. So make sure you have that in your tray. So once we get there, the next question is, And so this is how it looks like. The setup for this is so much simpler than any fusion you can imagine. It's one tray that bring in. It's basically a microdiscectomy or laminectomy tray that they open up, and you drop in those cast spar pins. Yeah, you have it facing away from you, and then you can open and distract, and it gives you great visualization through a small opening. So a couple other key steps, I mentioned those as well. So this is what it should look like. The one on the top is a little higher. There's no way around it because this is a 2-level case. So that's why it seems a little bit further dorsal than at the 4 or 5, but this is what it looks like intraoperatively. Again, you want to make sure that you don't over crimp, because that's not where this purchase is. The purchase is down at the lamina. I asked my residents to pull just a couple of cases that we've done recently, but we have cases that I have experienced this for 10 years out. And again, it's a durable solution. So some people think that this might be just a bridge until they end up needing the fusion, but in most cases, they never need a fusion. Of all of the patients I've done, and it's over a couple hundred patients at this point, they don't, when they come back, it's usually not for problems at the index level. So it's not 100%. They do have they can still have adjacent level problems. And when they come with adjacent level problems, then you have to deal with those. I haven't done a 3-level Coflex, but I'm sure that there are cases out there as well. I would consider it, but it would also be off-label. Any questions about the technique so far?
I like your Casper pin project. And by the way, Dr. Gold is doing a project, a retrospective study, but a larger one on Casper pins for anterior cervical discectomies. We're not talking about that here right now, but without taking it away, it looks like they're clearly better in terms of decompression technique and alignment than the non-Casper pin technique. So how long are your pins? Are they 25 or are they special length or are they standard 16
No, the
or
14,
18 millimeter?
yeah.
14 even,
Usually
yeah.
14, yeah.
And that's sufficient purchase. They
Yeah.
don't immediately
So,
lose.
yeah, so sometimes I get a little bit, the problem is when you're doing 2 levels. So if the first level, the pins are fine if you're just doing a single level. But if you're using the same Caspar pin for the second level, the one that you're reusing, so if, 3, 4, and 4, 5, the pin at 4 starts to loosen by the second. Mm-hmm. And so I've had some where it breaks off. It doesn't break off the whole spinous process, but it just breaks off and you lose some of that. And so sometimes with that one, I've also used the laminar spreaders. There's a little interlaminar spreaders. You can bring that in, but those aren't as sturdy. You bump them, they'll pop off. So again, extant or someone's going to come up with a better spinous process retractors that are low profile, stay away from the field, and have less chance of breaking these things. So again, I think that's, if anybody's still doing open, standard, take out the whole lamina, you don't need to do that anymore.
I totally agree. Then talk to us about flipping these devices around. So you show how there's a kind of a classic alignment, but you're fully allowed to flip them around so that the winglets are the opposite side.
Right.
When do you do that? When is that advantageous?
If I start at that's why you want to start from the bottom. You want to start at the lower level first and then work on up. That way you can put it in this alignment, right? But sometimes you forget. So if you forget, then you flip it around.
So
but
there's
usually you want the 3 teeth on the bottom.
Yeah. So yeah, I was always amazed, but the company and the FDA has fully approved that you can flip them around also and do it in reverse. So I side with you. I'd like to have this alignment, but the opposite is fine also.
Right.
And in this case, hypothetically, you could have put the device into 3-4, which is less severe, and then put in 4 or 5 secondarily.
So yeah, so I think, again, one of the reasons why I think I have had less problems with complications in terms of implant failure, spinous process fracture, is I do spend some time really shaping that spinous process before. So after I put the cast bar pins in here, I just drop that drill right down to this area here and then flatten this out. Similarly, I do the same thing on the other side, on the inferior spinous process. If there's a hump there, I flatten that out as well. Because again, if you look at the shape of this Coflex device, they're parallel, they're straight, they're not curved. So in order to get that better fit there, it spreads out the forces more evenly, and so they're less likely to have fractures in extension. Okay. So I don't worry about as much about patients post-operatively with extension. Again, I worry if they're a yoga instructor and they're doing a lot of flexion, because that's the part that really can open up that interlaminar space and dislodge this. So certainly in the early period, I ask them to avoid that. This patient is, I think, was 79. She's not doing any yoga. But that is one of the restrictions I have for my patients post-operatively, especially a lot of flexion exercises.
Great.
Dr. O, when it comes to intraoperative spinous process fracture, would you have abandoned the Coflex? And what would you say your rate of intraoperative spinous process fracture is where you do need to kind of abandon using?
I've had two. So they were early on. So I haven't had any since I've adopted. I've been much more careful about the spinous process shaping, because the fractures happen when you're trying to oversize it. So it happened early on when I was doing this, when I was over crimping it, because I thought that this was a spinous process device, and it's not a spinous process device, it's interlaminar. So over crimping it can cause that weakening, and also oversizing it. So instead of oversizing it, I want to shape the spinous process to accept it more than to oversize it. I don't want to create kyphosis, and that's another hit that this device takes, is that why would you want to put in a device that puts a patient into kyphosis? You don't. That's the answer. You just shape the device and you try to get them in neutral. That's why you don't want to use, at least I don't use a Wilson frame. I put them on a Jackson table so that I know the lordosis that I want, and then I use the Casper pins to get me that distraction temporarily, and then I let off that distraction when I'm sizing it and putting in the implant.
Dr. Richard Emanuel wants to know where you put the pins in, so I'm going to give you my high-tech pen, and maybe you can show on the plastic model.
So as soon as I make my incision, you dissect down, you feel the first spinous process, you start taking off the ligament on both sides, and you generally know that the spinous process is angled. So you don't want to put it perpendicular to the floor. You want to put it, you manually feel where that spinous process is, you feel the top and bottom, you go right for the middle of the spinous process. So it's all tactile feel. You don't use fluoroscopy or anything to put the Casper in. You just feel it, feel the top and
Move your hand a
bottom.
little bit so that you have an overhead camera behind you. So
Okay.
just turn yourself around a little bit. Yeah, thank you. So we have an unequivocally clear view. Thank you so much.
Sorry. So yeah. So again, you just put your finger down, feel the top, bottom, the sides. You've already taken down the ligaments. Not perpendicular, but you know the direction of the spinous process, and you tap it a couple times, get some purchase, and then twist it in, and that's good. So you get your spinous process clamps, Casper pins in there and there. That's it.
Okay.
So oftentimes you don't have to expose all the way. You just have to feel the top and the bottoms. So when I'm taking down the ligaments, I only take down this part here, this part, and just expose the bottom of this lamina and top here. As you saw in the video there, I don't make a big opening. I just go out to the facet. I don't expose much of the facet at all. I don't want to devascularize that joint.
Great, thank you. All right.
Right. So this patient did well. Here's another patient, 60-year-old male, back pain that radiates down bilateral legs equally. Patient pain improved with bending forward, worse with walking, so classic neurogenic claudication. And that's, again, what you want. The problem is when you start extending the indication. So when we do something off-label, for example, 3 levels or adjacent to a previous fusion, I think that we get away with that a lot of times, but when we start extending the indication, we're saying, well, I've had such good success with this, why don't I start putting these things in for back pain? That's when I think you're going to have some failures, because that's not what this was intended for. You have to have patients that have neurogenic claudication as their primary complaint. Lumbar stenosis symptoms, radicular symptoms. And again, if, in my mind, they have a little spondylolisthesis there, and I get uprights and doesn't move, so it's a fairly static. This is something we see all the time. If this patient comes to me and their primary complaint is back pain, I'm still not going to fuse them. I'm going to send them to one of my pain colleagues, or I'm going to consider doing, this patient doesn't have motor changes, but if they have a lot of muscle atrophy, I'll just consider stimulators or some multifidus stimulator or something like that. But this patient has the indication for Coflex or a fusion. So in a patient that has lumbar stenosis, neurogenic claudication with a spondylolisthesis, I'd say a good percentage of them, even if it's static, end up with a fusion. And the argument always is that in order to get a good decompression, I'm going to destabilize this joint, and it's already. And what I'm saying today is, with the technique that I described and with a Coflex device, you don't need to fuse these patients. Even if you're worried about them slipping, at least you're going to maintain some segmental stability by putting in an interlaminar stabilization device. And so I think this is an ideal candidate. And this is how I started my practice with Coflex, is it's someone that I'm thinking maybe needs a fusion because I might take too much of that joint, even though there's no clear instability on flexion extension, maybe a fusion, but the disc doesn't look that bad, don't want to do a T-lift, why do a fusion at all? So this is the kind of patient that I started with, and I still is probably the majority of the patients that I do these Coflex devices on. Started with this patient. The last patient that I showed you was more of a LAMI plus, someone that would normally just do a laminectomy on, but now I'm adding a Coflex. And again, the reason why I add the Coflex is because of the back pain. They have significant back pain in addition to their neurogenic claudican symptoms. This patient will look like this. The other one, we didn't show the sizer, but there is a sizer that comes with the kit to determine. This patient has a larger implant. You can see that there is some over-distraction on this one because you can see the vacuum disc phenomenon over there. So that's certainly something to watch out for. We followed this patient and doing exceptionally well, resolution of all pain. This is one of, sounds like some of your patients where they're very active. His version of active was pickleball. I'm getting more and more patients where they are in their 80s and very fit and very active, and they are all afraid of the F word. And nobody wants a fusion. You can't talk them into a fusion, even if you wanted to. But now with this type of procedure, you don't have to talk them into anything. You can offer them a non-fusion alternative that maintains some stability, maintain that foramina height, address the neurogenic claudication symptoms because you're doing a really good decompression, as well as providing them some facet offloading, stabilization, and improvement of their back pain. And that's what I'm seeing in almost all of these patients. So 2 months, 6 months x-rays, you could see that it's still moving. And if you follow these patients long enough, and the reason why I don't have 10-year data on these patients is most of them don't come back. And they don't come back. In cases of fusion, a lot of times they don't come back because they went to see someone else to get another fusion. because they think that you did something wrong. But in these patients, I think they don't come back because they're doing well and they have less adjacent segment disease.
This is a particularly evocative case, Dr. O, because of course there's the target of the grade 1 degenerative spondy at L4-5 with stenosis, but this patient also has degenerative disc disease at L5-S1. And had we fused this patient at 4-5, this is the age-old conundrum of if this patient comes back with almost inevitable back pain, should we have fused to S1? That just then begets this whole series of further thoughts. Do we have to go to the pelvis in a postmenopausal female? So here we have an L4 to S1, S2, or pelvis fusion, and we literally set up the spine for this chain reaction up the hill. So I'm obviously heavily conflicted, but I'm in full concordance that this is a great master example of a superiority of a stabilization device being meritorious rather than a fusion.
Right. So here's my third and last case. It almost sounds just like the previous ones. A 68-year-old female, chronic low back pain, radicular symptoms. Pain is worse with walking, better with sitting. I'd like to see that. But this patient had quite a bit of back pain as well. And they came to me without any upright x-rays. So I was thinking here's a lot of stenosis there. That's just what you would expect. A little problem with that facet joint. Grade 1 spondy. Looks almost identical to the last case based on the MRI, but the x-rays tell a very different story. You can see that just even without getting flexion extension, that upright x-ray looks very different. And with flexion, you can see that the focal kyphosis that's there. This patient is not a Coflex patient. It's not a non-fusion stabilization. So this patient was signed up for standard transforaminal lumbar interbody fusion. That's what we did, and they did well. So Dr. Chapman kept asking the question, did you get flexion extension? Did you get flexion extension? This is the reason why. You have to get some dynamic study before you decide fusion, non-fusion. If you're deciding non-fusion, Coflex is a good alternative, a good option. And I think if you adopt some of the techniques that I mentioned about how to do the decompression, that this type of procedure will be great in your hands as it has been in my hands. Time for some questions?
Great, yeah, great lecture. Beautiful video. In lieu of questions, maybe can I join you on the podium?
Sure.
And I'll ask Corey to help me plug in my computer. I just wanted to hear your opinions on a couple of thoughts. So I'm not trying to lecture past your lecture here, but I'd love to have you co-present with me on a couple of talking points. So Corey is plugging this in. Any questions from you guys? Pins? I think the pins are an ingenious idea. I hadn't thought about that. I'm obviously a fan of pins for the cervical spine, as Dr. Gold knows. And I will certainly look at that. So spondy, and to be very clear, we're talking about degenerative spondies, not isthmic spondies. I want to make this, for anybody in the audience who has questions, abundantly clear. I think we can all agree that these are kind of the classic things we look at. Am I forgetting something in this basic checklist?
No, that's very good.
So, but here, one thing I want to just point out, and this is something I'd like you to address. There's been so much attention placed on posture and alignment. I mean, we all are cursed nowadays when we don't, like Dr. Gold said so nicely, show the alignment goals of patients. Talk to us about the escape posture in stenosis patients. This is real, and how can we differentiate that clinically? Escape posture, that forward bending posture to escape the neural impingement. Real or not?
No, that's definitely real.
How can we differentiate that clinically? Because if you look at the alignment of a lot of these people, they kind of stand hunched, they clinically stand hunched. Are flexion extensions the way to rule that out, or what do we do?
So I think it's the upright x-ray flexion extension views. I don't think in a patient that's 75, 80 years old, we're not going to do a 10 to pelvis, well, I'm not going to do a 10 to pelvis kind of reconstruction anyway. There's no reason, I don't need to get that scoliosis. I do need to get their upright x-rays and see how much flexion, if it opens up at that index level. So this one here is showing me the great.
So I'm just showing a couple of things in terms of low discs, high discs, neutral angles, kyphosis of the disc space, gas. So these are some of the variables that I'm looking for. Do we have a formula for those? How, for instance, does a high versus a low disc affect your decision making? You showed a patient with a beautifully preserved disc for your Coflex.
Right, yeah. So if they have significantly degenerated discs, the part that bothers me is determining back pain. So if they have severe degenerated disc, then I know, then I'm in the conundrum, how much of their pain is coming from their disc versus their facet joints. So in those patients, the idea of just putting a Coflex device, even if I offload that facet joint, I might be putting them in a little bit more kyphosis, causing more anterior column pain because they have that degenerated disc. So the decision-making takes me, once they have a significant degenerated disc, then I start thinking more of a fusion.
And then
Same thing with the vacuum disc phenomenon.
and that's a good candidate. That's not a contraindication, right?
It's not a contraindication, but I generally start thinking of fusion devices rather than a Coflex if they have significant, because the Coflex device is really meant for offloading the facet. It does, if you oversize it, you can actually cause more discogenic or vertebrogenic pain. So I worry about patients that have either a lot of degenerative disc disease, vacuum disc phenomenon, those kind of sclerotic end plate changes you show here, the grade 1 spotty. Those patients, I tend to go away from the Coflex, actually.
So one question in the beginning of all these interspinous and interlaminar devices was that they're kyphogenic. Is that true or false? Are they kyphogenic?
I think the interspinous process devices have to be kyphogenic because they depend on indirect decompression. So all of the interspinous process, the former X-stops, the current ones that they use right now, what is it called, Vertiflex, those all have to be kyphogenic because you're trying to get indirect decompression by putting something, spacer in between. But with properly done Coflex case, because you're doing direct decompression, if you shave off that spinous process properly, it shouldn't be kyphogenic at all.
And then we talked about, we still have 4 minutes or so, facet joint alignment. So talk to us about the importance of alignment of the facet joint relative to a pure decompression, like on the left, we have a pure coronal joint, and then the facet joint angle over 45 or 50 degrees, like what Dr. Davis said. So how much does that influence your decision of pure decompression versus a stabilization versus a fusion?
So, and as we know, this angle changes as you go up. So what I've seen is the problems that I see with post-laminectomy spondylolisthesis or slips is when you have more of the sagittal alignment, and that's going to be starting at 3-4. When you're down at 4-5, most people have the facet angulation so that if you're careful with your medial facetectomy, if you don't take it out to 50%, your risk of developing a post-lami slip is low. But as you go up higher, 3-4, 2-3, then that angle becomes more narrow, steeper. And even if you take off a little bit of that facet, you're going to have much more propensity to develop a post-laminectomy spondylolisthesis. That's why the further up we go, the more I'm inclined to do mini open at 3-4 and 2-3. At 4-5, I'm much more inclined to do, if I'm doing simple decompression, I'm much more inclined to go in with a tube.
I think this is a very valuable point, and I'm so glad to hear a colleague of your esteem concur that the era of the full laminectomy should be over. And then the fluid sign, you showed several cases of fluid. We addressed that before. There's some case examples. How does facet joint fluid, again, in terms of quantitative statements and in terms of dysmorphism or tropism, affect your decision-making?
So if I see someone with this less than 2 millimeter mouth facet fluid, when I get upright x-rays and I don't see any abnormal movement, it's as though it doesn't affect it at all. It's when it becomes greater than 2 millimeters. When you have advanced fluid in the facet joint, almost always they're going to have some subtle abnormal movement. So I'm much more attuned to look for that in the upright x-rays. I'm much more attuned to asking them specifically what kind of back pain they have, whether it's inflection or it's an extension. Those all give me an idea of how much this facet joint is going to be a problem. But if I see fluid like that, even 2 millimeters, as long as they don't have clear abnormal movement, I would still consider doing the Coflex. It wouldn't prohibit me from doing a Coflex device, because I think that Coflex will, at this level of degeneration, will still offload and protect that joint. Whereas if there's instability, and you see it on the upright x-rays, then it's clearly going to be a fusion case, not a Coflex case.
So it's a gradient, and again, from dysmorphism to tropism, where there's asymmetry of the joints, that's the other variable. So for me, this is my current checklist. It's 15 points, and I'm not shy about this. I love KISS, the band KISS. Okay, you can draw your own conclusion of this, but I like the principle of keep it simple, etc. But there are 15 points that matter. And again, patient symptoms and health expectations are the probably most significant things. Last night, we talked about AI. Is this something where we can have a machine learning tool that provides a more structured analysis and then a weighting of all these various things? Is this something that we should kind of try to start teaching or looking at in greater detail?
I think AI is going to influence this, but it doesn't, until we have really robust registries, and that's what American Spine Registry is trying to do. Unless we have that kind of registry, it's going to be hard to parse out all the data that's necessary for artificial intelligence. In order for AI to work, you have to have these large data sets that are publicly available. And we're in medicine, we're so protective about our patient data, and there's so many regulations regarding patient data that it's hard to get those kind of large data sets where you have the diagnosis, the surgery, and the outcomes, long-term outcomes, all detailed and tagged appropriately for AI to work. This checklist reminds me of, I'm not trying to make fun of you, but it reminds me of the checklist when I go to the VA, is that it's just too long. For me, for a checklist to work, it has to be 3 or 4 things. And so for me, it has to be back pain versus leg pain, upright x-rays, is there any instability? And then in terms of the procedure, is the size of the patient, so size and weight of the patient, because that tells me whether I'm going to try to do it through a tube or I'm going to try to do it mini open. So those are the few patient factors and a few radiographic factors that really is my checklist.
So we started 5 minutes late. Dr. Hogshead, microphone, yeah.
Dr. O, on your, as you mentioned, short list of considerations, was bone health on that list, and how does that affect whether you decide for Coflex or not?
Yeah, so because this device is, even though it's a non-fusion device, you still don't want to put it in someone with osteoporosis. That's when you're going to have problems with fracture. I am a little bit more lenient because it's a non-fusion device, so if they're osteopenic, I'll still use a Coflex device. But certainly with osteoporosis, you got to get the osteoporosis treated first.
Great points. So we started 5 minutes late, we ran 5 minutes over, but this is a very valuable time. We didn't even delve into the hornet's nest of insurance reimbursement because, believe it or not, at least in our state, there's still a lot of insurance carriers who deny these and rather have us fuse patients. So, but we've had the same observation. Patients here are really cognizant of fusions and would like to avoid fusions. We have that same phenomenon up here in Washington State. Thank you, Dr. O. True pleasure. Thank you. Corey, can you take